Thank you, Dr. Agarwal, and thank you, Dr. Ram. I would like to invite Dr. Manasi to felicitate our dear speaker, Dr. Indra Agarwal, and our moderator, Dr. Ram. So moving on to the next topic, it's posterior urethral valve, session on management. The speaker would be Dr. Ramesh Babu S. from Sri Ramachandra Institute of Higher Education and Research, Porur. And a moderator of a session would be Dr. Madhubhashni, Senior Consultant, General Medicine and Diabetologist here in Kauvery Radial Road.
Hello. Thank you, Dr. Sangeeta, for asking me to give this talk. Um, I will try to make it as simple as possible because we have a lot of physicians here. I don't want to complicate this talk. Not getting late here. So this is wadding cystourethrogram or an MCU. This is a normal wadding cystourethrogram. And this is the third one is the classical posterior valve. And one in the middle is something like a suspicious one. There are multiple issues here. When you deal with the posterior valves, a classical one, I mean, I'm not talking about the one in the middle, I'm talking about the classical posterior valve, this one. Antenatal counseling, severity assessment, the role of termination, role of intervention, then what are the neonatal issues, what are the role for diversions, and then the long term wetting, urinary tract infections, renal impairment, growth, bladder dysfunction, CKD, ESRD. So many problems are there, and we need to be aware of all of that. So I'll illustrate with some case scenarios here. As we go by, we'll bring in the points. So this is an antenatal scan of how many weeks? 19 weeks. 19 weeks gestation. Keyhole sign. The keyhole sign is a combination of dilated bladder and dilated posterior urethra and hydramnios. That means no liquor and then echogenic kidneys. So when you have this combination, they have very poor prognosis, particularly in the terms of renal outcome. Even in the newborn period, they can actually go for severe renal failure, leading to dialysis and all whatnot. So even the survival can be difficult because these patients go for pulmonary hyperplasia and then lung outcomes also can be affected. So these patients, they are really bad, they are informed of the serious nature of the disease and the parents decide to go for termination. Now this is another case who got diagnosed at 24 weeks. So in our current legal scenario, 24 weeks is the cutoff. So if your anomaly scan picks up something and you made a decision before that, you're fine, good to go ahead and terminate. So this was picked up at 24 weeks and 3 days. And this is a typical keyhole sign I was talking about. This is just imagine it like a little bit anti-clockwise here. This is the keyhole, bladder and the posterior urethra. Both kidneys are dilated. So we could not terminate this patient legally because they are beyond the age of termination. And at 33 weeks by LSCS, this is baby was delivered with a severe oligohydramnios. Then the baby was intubated due to poor respiratory effort at birth, received a surfactant, a lot of electrolyte abnormalities, and you can see that that is how bad the X-ray was before and after. And the baby also had a one-sided multicystic dysplastic kidney, which is basically non-functioning kidney. And at birth, you can see the creatinine levels, so 2.8, 4.9, 2.2, 1.7, 1.9. So the baby never got into a normal creatinine at all. So a loop ureterostomy was performed, and that's a temporizing procedure where you temporarily relieve the obstruction. It was admitted multiple times with the seizures, hypercalcemia, metabolic acidosis, hyperkalemia, hyperlactemia, you name a thing, the baby had hyperphosphatemia, hypertension, multiple admissions with the electrolyte abnormalities, neurosepsis. Baby is now 6 years old with the ureterostomy. We've just closed the ureterostomy because the baby is now gone on a transplant waiting list. Still 9 kgs, multiple medications, erythropoietin, and the baby is on hemodialysis. So you can see that, if you miss the chance of the severe one, then this is the situation. But that is not always the situation. So I'll come towards the end of the talk how often we have this bad situation. Now this is a 26-weeker. Severe bilateral hydroureteronephrosis and oligohydramnios. This is also again the keyhole sign, the bladder and dilated urethra. So what are the indications for fetal intervention, success, risk, and what counseling we offer for them? So normal karyotype, salvageable renal function, which means that the fetal urine has got a favorable electrolytes. And these are the options. You have a shunt, you have a fetoscopic valve fulmination. Now this is a modified Romano staging for fetal lower urinary intervention. So they have multiple stages here, stage 1, 2, 3 and 4 based on the severity of the amniotic fluid. Amniotic fluid is normal, renal echogenesis is normal, there's no renal dysplasia, then biochemistry. So they do urine sampling. They have to do 3 fetal urine samplings. That is a invasive procedure, ultrasound guided puncture of the mother's uterus and then the baby's bladder. You can see they go through multiple layers, and if everything is normal, then you really don't need to intervene. On the other hand, if everything is really bad at the other extreme, anhydramnios, echogenic kidneys, and all whatnot, there also the chance of having any intervention is very limited. Even in the stage 3, you don't. But in the stage 2, there is a salvageable renal function, so that is the case where some intervention can be of help. But again, there was a lot of trials which went on about this particular the trial called Pluto trial, which looked at the benefit versus harm. So the amniotic shunting basically helped them with the recovery of the lung function, but not the renal function. So the kidney failure risk is not altered. So other issues where there was a very high chance, 20 to 60% shunt displacement. So the babies have hands and foot and various things to move around. And this stent is not anchored, it is just hanging in under the baby's abdominal wall onto the amniotic fluid. So when the baby comes, baby delivered with the stent in the hand, the baby. Then 33% of babies require dialysis still, and complication rates and miscarriage. So it never took off basically. So the antenatal interventions, then fetoscopy. Again, fetoscopy has got multiple problems. So here you are putting the cystoscope through the baby's mother's abdomen, mother's uterus, into the baby's abdomen, into the baby's bladder. So you are going through 4 different walls, and so 10% risk of urethral damage, 5% risk of recurrence, and overcoming the angulation of the bladder neck is not it's technically challenging, and paradoxically, fetal intervention may add to the burden of morbidity and renal failure. That's who otherwise may have succumbed to the lethal pulmonary hyperplasia. So it never basically took off. However, this is the flow chart. If someone is really interested in fetal intervention, that is how we go through. And then, if there is a mature lungs and if there's a salvageable renal function, then that is a small group of patients who might benefit it at the risk of miscarriage and infections. Stable posturethral valve in a preterm baby. So this is a antenatally diagnosed bilateral hydronephrosis delivered at 36 weeks. Birth weight was 3 kilos. So is this amenable for primary fulguration? So we get a lot of patients like this, and if they come like this, then they are very good candidates. So we have a 4.5 to 6.5 cystoscope and Bugbee electrode, and then we also have for term babies we have the resectoscope set. Multiple sets are available, and we use a cold knife, and we have published that the results of using the cold knife is pretty good. Now, primary valve ablation, if feasible, is preferred by the majority because it enables the bladder recycling, bladder growth, and so that is the most preferred method of management. So we follow them up with the repeat MCU, and then we just look at the posterior urethra anterior urethra ratio, and then if the ratio is improved, then we don't have to worry about them anymore. Now this is a newborn who is complicated by urinoma. So urinoma is the leakage of urine from around the kidney, usually the calyces rupture, and so this is the kidney. Outside the kidney there is a urine collection, and when we did the MCU, you can see the contrast has actually gone outside the kidneys. So it's leaking outside the kidneys. So this baby was stabilized first with the nephrostomy. In this case, the nephrostomy is only one flow. So this patient then went with the drainage of the urinoma. After that, we have to stabilize the patient also. Most of these patients, the stabilization involves antibiotics, correcting the electrolytes, then correcting the fluid balance, all that. And then we also tend to get an MCU if they are stable. So there is an ultrasound being done, and then there is the ultrasound guided aspiration of the urinoma, urine collection. So that is the, you will see that? Yeah. So that is the urinoma which is being aspirated there. And once that is done, we go for the valve calculation. So in this patient, you can see the jaundice urine, all newborns are like that. So this is a cold knife, is what I was mentioning. So we have a sickle-like cutting mechanism there in a cystoscope. If you pass it, that is the valve. The valve is only a few millimeters. It's a thin leaflet, but the amount of damage that the leaflet causes is enormous. So we cut it at 3 positions, like 12 o'clock, 3 o'clock, and 5 o'clock, and then after that, they get better, right? So that is what we have done in this patient. Now, this is another patient who underwent 31-week fetus with a keyhole sign and oligohydramnios, bilateral hydroureteronephrosis, and so this is a LSCS was performed at 34 weeks. So we got a 2-kilo baby who warranted a CPAP for 24 hours. So bilateral gross hydroureteronephrosis, and baby was catheterized. On-table MCU was performed, which confirmed posterior urethral valve. So here the cystoscope we used was the smaller one, and then we used a laser. So with the laser current, we could buzz the valve at multiple places and then ensure that the valve is cleared. So that's the laser fulguration of the valve, and then at 2-3 positions we kind of buzz that, and once that is done, we clear the valves. So long-term issues, the term valve bladder covers all the dysfunctional bladders in patients with the posterior valve. It was first used by Mitchell, who described the pathophysiology where the underlying obstruction initiates a cyclical event leading to bladder decompensation. So they typically present with the wetting, daytime wetting at the age of 4 to 5, persistent hydrourinophrosis, rising creatinine, they need uroflow, repeat MCU, and then urodynamic study. So depending upon the shape of the bladder, the trabeculations and the presence of reflux and diverticulum, the severity can be scored. So we have also introduced this bladder height width ratio on avoiding cystourethral as a predictor. So if the bladder height width ratio after fulguration is still high, they have a very high risk of developing a valve bladder. On the other hand, in many patients, the bladder contour improves after the valve fulguration. So in those patients, they have a very good bladder outcome. So in a patient who develops a stricture, this is a flat uroflow, and in a patient who develops a valve bladder, who have a valsalva body, and this is how the uroflow is there. And this is the urodynamic study, which goes, the pressure keeps on increasing. So this is a high pressure uroflow. Syndrome of nocturnal overdistension. SNOB refers to polyuria, nocturnal polyuria, and then the bladder gets more distended, and they need a nighttime catheterization. So valve bladder is basically a vicious cycle where the posterior urethral valve causes detrusor hypertrophy, then increased intravesical pressure. The pressure is transmitted to the upper tract, impaired renal function and concentration availability, increased urine output, then again impaired bladder emptying. So more difficult to bladder, but more output, which is like polyuria, and then that worsens the valve. So they go through the stages of bladder instability, impaired compliance, poor bladder emptying, and myogenic failure. So the first thing we do is to exclude a residual valve, because some of them have residual valve or structure. Then we can give them anticholinergics and alpha blockers. Then we can suggest a timed voiding, double voiding, CAC, nighttime drainage, and then urodynamics and augmentation or metrophone. So we looked at the role of mirabegron. Mirabegron is a beta-3 agonist. The multiple medications we use. So basically, in a patient with a persistent hydrourinophrosis, we exclude the residual valve or structure, then we do urodynamics. If they have a bladder neck hypertrophy, we go for alpha blockers. If they have hyperactivity, we can either do anticholinergics or beta agonists, which is a mirabegron. And then we can use, if they have a decompensated bladder, then we have to use a nighttime drainage. So when we tried this mirabegron, it was very effective in our group of patients. Now, solifenacin is a newer generation new anticholinergic, which has got less side effects. The conventional anticholinergic is oxybutynin, which has got increased constipation, hyperpyrexia, and it also causes cognitive disturbances, which is really disturbing these children. So when we go to solifenacin, it is available as a suspension nowadays. So that we have tried, and we have started doing a trial on this and see whether this works better. And our early results show that solifenacin is definitely superior to oxybutynin. This is a 10-year-old boy who had a dribbling of urine and UTI. He was diagnosed at birth, bilateral uretrostomy in the newborn period, then closure of uretrostomy later. He came again at age 12 with urgency dribbling and a creatinine of 2.4. Urodynamics, his pressures went up to 35 cc, and then he had a leak at 140 cc, and he had a poor function on the right. So this is the picture. So he has been on anticholinergics and nighttime drainage with deteriorating renal function. So what we did was the non-functioning kidney we removed, and then we used the ureter to augment the bladder. So that's a ureterocystoplasty, kind of a bladder augmentation. This is a 16-year-old boy who presented with acute retention of urine, history of dribbling from childhood, and then cystoscopy revealed the posterior urethral valve. He drained 1.5 liter of urine, and this is how his bladder was at the time of presentation, how big it was reaching up the liver. So large capacity bladder, they typically void with abdominal straining with the poor P detrusor. That means that the detrusor is not contracting, but the abdomen is only, the abdominal pressure is only there using. So what are the options prior to transplantation? We have to make sure that the bladder gains the shape and contour and the contractility. So they need a clean intermittent catheterization as well as nighttime cradles. So pre-transplantation workup, we always have to um, assess the bladder. The bladder looks a bit like a neurogenic abnormality. That is not neurogenic, but basically valve-induced damage. A lot of pressures are there. Then the biggest question is whether we have to augment and do a Mitrofanov prior to transplant, or you don't do it and then do the transplant and bring out the ureterostomy or into an alveolar conduit. So that's the biggest debate we have. Now we have proposed this prognostic grading of posterior urethral valve, where PUV 0 is not even a valve; it's a suspicious fold. You have no classical leaflets. There is everything is normal. And then PUV can be multiple grades, mild oligo, moderate oligo, and severe oligo. Then the renal function was already normal or recoverable or very bad even after treatment. Then post fulguration, what happens to the kidneys, kidney status, bladder status, based on all that. So we looked at our patients over the last 20 years. So we have around 30% of them were only suspicious PUVs. They were not even PUVs. So it is unfair to brand them as a posterior urethral valve and then keep on doing some investigations. Whereas when we look at the classical posterior urethral valve patients, around a third of them belong to the middle one. Around another third is the mild ones, which are doing very good prognosis. So around some 1/4 of the patients of posterior urethral valve have very good prognosis, whereas around 10% of the patients are the ones who end up in CKD. When we look at CKD free survival, this kind of grade, the PUV grade 3 are the ones which go for very fast into renal transplantation and bladder damage as we follow them over the 20-year period. So this is the pictures of what we are proposing. This is an unpublished data. We are going to present it in the forthcoming ESPU Congress in Vienna. So when we have this suspicious valve, you have elongated urethra, some kinkings and folds, they are not even posterior valve. So they should not be branded as posterior. When you have a classical posterior valve, again, they have three types. The one which becomes completely normal, the renal function was absolutely normal. Or the one which has got some changes, but the renal function is recoverable. So they both do extremely good, and they have very good prognosis following a prompt intervention. Whereas the one which is 10% population who are still worse even after treatment, prompt treatment. So they are the ones who have a high risk of CKD progression and despite treatment. The urinary tract infection in children should be evaluated fully. Urosepsis is still a common presentation in India. Bilateral hydronephrosis in a boy child in an antenatal scan. PUV until proven otherwise. So this is very important. Primary fulguration is highly effective. Older children, watch out for those with the intermittent retention, poor flow, staccato voiding. We still see every year 1 or 2 patients who are missed. Then antenatal counseling is a huge challenge. So we have to weigh the risk versus benefit, and then the decision to terminate or do a fetal intervention is a major decision, and that's an important point to be considered. Thank you for your patient listening.
Thank you, sir. That was an excellent talk. We got some data much earlier than international audience. Privileged.
Yeah.
Any questions?
Just a comment. Just that if our patients are diagnosed to have valve at 10 years, 13 years, 16 years, we also come across this in our clinics. And you just feel sad that there were probably symptoms that were missed when they were in childhood. Probably some of them have had urinary infections. Some of them had symptoms to suggest urinary infection, just simple fevers. But what we often, how we teach them that some fevers are treated with antibiotics, and they are probably treating a UTI, so they don't really know they're having urine infection. So I think we really have to sensitize our pediatricians. It starts with the UTI or a good antenatal scan that itself. And I think antenatal scans are improving now, more and more people are doing it. So promote good antenatal scans and pick up telltale signs quite early. When we do see these children coming in with large, some intermittent abdominal pain, but nobody doesn't ultrasound. We don't expect an abdominal pain to be a hydronephrosis. Unfortunately, we're still seeing these things, and it's sad when they come already with CKD by that time. So I just hope that in future we are able to sensitize our pediatricians enough to pick up these things.
Sangeeta, you want to add anything? Because we have seen some of these patients which are, these are two challenges. One is a late presenter, other one is early diagnosis in antenatal, but they are already severe, already bad.
Late presentation, we have seen children at 12 years to 15 years presenting with palpable bladder, and at the time itself the creatinine was around 5, 6. We have to stabilize the children with the dialysis. It is very sad to see those scenarios. And at the same time, even the antenatally diagnosed, postnatally urine stream was never noted by the parents. That ignorance is also still there. So they should be educated. Counseling, repeated counseling only will help the parents to pick up those signs earlier. And even the doctors, pediatricians or the general practitioners should know that how important the history is. How is the stream of the urine? That is very, very important in a male child.
I should also say that we have some of the patients who are doing extremely well after post-urethral valve. So that is the other side of the coin where they've done beautifully. Their ultrasounds have become normal, their BP is never high, and their creatinine is normalized. We see that also. So I think it's important more and more CMEs like this to keep on talking. It doesn't matter if they get bored.
Why are these keyhole things missed at the 20-week scan? What is the reason?
I would say this to all physicians basically. When you ask for a test, you should get the test done only when you get a confident result that you should be able to confidently say that this is normal. You ask for thyroid levels. You want to send it to a proper lab. To say that something is normal, it needs a lot of experience and guts. So everybody is doing now fetal scans, at least that anomaly scan, like 18-week scan, should be done only at a center where a fetal scan is done. Because a fetal anomaly scan, you don't know how far it takes. It takes nearly 1 hour or 2 hours. They have to look at each and every organ carefully. And if that is done as a part of a 100-patient outpatient, it's not going to work.
There's no way that it can be missed.
At least one scan should be done.
No, I'm asking, even by a very skilled person, is there a possibility that they can miss this at 20 weeks?
I won't say miss, but there are some dissipating valves or mild valves, which the baby itself with the flow gets better.
But that doesn't matter.
That doesn't matter.
Yeah.
Exactly. These are mildest versions who don't matter. But the proper severe ones will get missed. Will get picked up.
Will get picked.
You discussed about the extremes of cases. One is a severe antenatal presentation, the other one is a late presentation. But there is a good chunk of babies with diagnosis of bilateral antenatal hydronephrosis, maybe 10 or 11, but they may not have gotten that detailed scan about the bladder or ureter distension. They are not commented. And even when we go for the first postnatal scan within the first week, most often radiologists do not give us the SFU grading, nor they tell about the thickness of the bladder or something. So how do we go about this chunk? Who form the majority? And when should we suspect the milder varieties of PUV?
Madam, this hydroureteronephrosis, bladder wall thickening, keyhole sign, these are all basic common findings which even a simple radiologist or a sonologist should be able to pick up because they are glaring at you. Any fluid is seen as black, and the ultrasound is fluid friendly, and this is a fluid distension, so they should not be missing it. Now, having a bilateral hydroureteronephrosis, whatever grade, bladder distension, keyhole sign, oligohydramnios is not a matter of concern because we have seen these patients because these are diagnostic features. We have seen them reversing completely after a prompt treatment. But what they should be looking for is echogenicity of the kidneys and the renal cortical cysts. So if these two findings are there, then they are the red herrings for you to say that this patient is not going to get better. So you think about termination even before 20 weeks. But to tell that, they need to look for it. So presence of hydroureteronephrosis and keyhole sign is a common finding. And oligo is also a common finding, and they cannot miss it. But telling about the kidney status is what we expect out of the sonologist. I mean, that is the grading. The grading, that is where this matters. Now, after that, whether we go for fetal sampling, urine sampling, and all, most of us we don't. Because by the time we know that the renal echogenicity is poor and cortical cysts are there and bilateral damage is there, or one side already multicystic, we can easily counsel them for whatever intervention. For the good ones, like what you said, we can easily reassure them that they will, I mean, the late diagnosed ones, where there is only hydroureteronephrosis and oligo, but the oligo is not very bad, there is no anhydramnios, renal cortical echogenicity is good. For them, I would suggest carry on till term and then do a term primary valve validation, do a check cystoscopy or a repeat MCU, and if it is clear, then they do extremely well because they are the ones with recoverable renal function. Thank you.
We are running out of time. Any further questions? We finish the session. Thank you so much.
Thank you so much, doctor. I would like Dr. Madhukar.